Good morning, everyone. I'm Dr. Felipe Temple Jr. So the lecture today is about acute phase reactants. The learning objectives of this lecture are to discuss the physiology of acute phase reactants and their importance in defining illness and injury, and to discuss the most common inflammatory markers utilized and how these markers can help in establishing the diagnosis of many disease entities. So, acute phase reaction is the general term attributed to a group of systemic and metabolic changes that occur within hours of an inflammatory stimulus. So the most important component of this response comprises the so-called acute phase proteins, or more commonly termed as acute phase reactants, which are basically a heterogeneous group of plasma proteins. The general principle in acute phase reactants is that the stronger the stimulus for inflammation, the greater is the change in the concentration of acute phase proteins and will continue the high levels as long as the stimulus remains. So during your systemic acute phase reactions and during your innate immunity, when your body encounters bacteria, virus, trauma, or even some kind of malignancy, there would be an acute or local acute inflammatory response, and different cytokines are involved. The first group consists of your interleukin-1, your TNF alpha, and your interleukin-6, acting into your hypothalamus, thus producing your prostaglandins and then the fever. This group will also stimulate your pituitary gland and then your adrenal cortex to produce your corticosteroids. The groups of interleukin-6 again and TNF alpha can also act in your bone marrow by increasing your colony-stimulating factor by stromal cells and macrophages, and thus there would be a leukocytosis or increase in white blood cells. Other cytokines would be your interleukin-1, TNF, and specifically your interleukin-6, which is the most important among cytokines that can stimulate your liver to produce acute phase proteins, mainly your C-reactive protein, your serum amyloid A, fibrinogen, your mannose binding protein, and complement components. In a nutshell, the inflammation in your body would be translated into the acute phase response. And through your interleukin-6, your liver is stimulated to produce your acute phase proteins or acute phase reactants, mainly your fibrinogen, haptoglobin, amyloid protein, and C-reactive protein. So again, during acute phase reaction, your interleukin-6 is the most important among cytokines that can stimulate your liver to produce these acute phase proteins. Again, like your CRP, your mannose-binding lectin, your complement components, your granulocyte colony-stimulating factor, as well as your proteins involved in your coagulation cascade. In general, your acute phase reactants or acute phase proteins are divided into three main groups. The first group is your major acute phase proteins. So these are a group of proteins that are elevated during the first few hours or first few days of inflammatory episodes, but also drop significantly afterwards. Your second group is your moderate acute phase proteins that are becoming elevated gradually, but the elevation is sustained over the course of the inflammation, lasting 1 to 2 weeks. The third group is your negative acute phase reactants or proteins wherein the level of these proteins drops significantly during the course of the inflammatory or inflammation. So in this lecture, we will discuss the acute phase reactants based on their significance or utility in the clinics. The most commonly used is your erythrocyte sedimentation rate. Strictly speaking, erythrocyte sedimentation rate is not an acute phase reactant, but is a procedure to measure your acute phase reactants. Next is your C-reactive protein or your CRP, followed by your fibrinogen, and less commonly used are your ferritin, your serum amyloid protein A, your alpha-1 anti-chymotrypsin, your alpha-1 antitrypsin, and of course your haptoglobulin, alpha-1 acid glucoprotein, ceruloplasmin, and C3 and C4. So the level of increase or decrease among acute phase reactants also vary. For instance, while the levels of CRP and serum amyloid protein A increase a few thousand folds, the levels of alpha-1 acid glycoprotein, your alpha-1 proteinase inhibitor, your haptoglobulin, and fibrinogen increase a few folds, and the levels of ceruloplasmin and complement proteins increase around 50%. On the other hand, the levels of albumin decrease during an acute inflammation process. So with this pattern of increase or decrease of the acute phase proteins, our positive acute phase reactants are mainly your C-reactive protein, your fibrinogen, which is mainly measured by your ESR, or your haptoglobin, and alpha-1 antitrypsin, while the most important negative acute phase reactants are your albumin and transferrin. As you can see in this slide, your acute phase proteins are grouped or can be grouped based on their normal physiologic functions. So we can see here the complement systems consisting of your C3, C4, C9, as well as factor B, C1 inhibitor, and MBL. And then we have proteins from your coagulation and fibrinolytic system like your fibrinogen and plasminogen. We also have your antiprotease or proteases like your alpha-1 protease inhibitor and your alpha-1 anti-chymotrypsin. We have your transport proteins like your ceruloplasmin, haptoglobulin, and hemopexin. And of course, we have other inflammatory responders, and we have the CRP, fibronectin, ferritin, angiotensinogen. Take note that the decreased proteins again are your albumin and transferrin, along with your transthyretin, thyroxine binding protein, insulin-like growth factor 1, and factor 12. So let's focus our discussion in the acute phase proteins most commonly used in clinical practice. So we will discuss now the erythrocyte sedimentation rate, your C-reactive protein, your fibrinogen, your serum ferritin, and of course we will include here your procalcitonin, which gained some recent utility at least during the last 5 to 10 years, while the rest of these acute phase reactants are generally used for research purposes. So as I mentioned earlier, your erythrocyte sedimentation rate, or your ESR, is one of the oldest methods to determine your acute phase reactant. Your erythrocyte sedimentation rate, or your ESR, indirectly reflects the increased concentration of acute phase reactants. It is cost efficient because it is cheap, accessible, available, and can be done easily in many laboratories, and it can assist in following up with the progress and response to treatment of a disease. The major determinant of your ESR is a so-called rouleau formation, from the French word which means a roll of paper or a cylinder. The protein which contribute to most erythrocyte sedimentation rate is actually fibrinogen, and to some extent your albumin, your alpha and beta globulin. So this is your rouleau formation or rouleau effect, wherein the cells are lined up in a single axis, like stacks of coin. The aggregation of erythrocyte is determined by the electrostatic forces. The erythrocytes are normally negatively charged and repel each other. On the other hand, many of the plasma proteins are positively charged and neutralize the charge on the erythrocyte membrane, therefore lessening the repellent force, contributing to your aggregation. This rule of formation is important to be differentiated from your true agglutination because this can be mistaken as a positive result during your cross-matching. There are few methods in performing your ESR. Historically, ESR is done manually using your Westergren method and a Winthrop method based on the tube used in the procedure. But nowadays, we have several automated methods. So this is the setup for your ESR using the manual method, specifically your Westergren method. So a specialized tube is filled with whole blood with anticoagulants and let it stand for about 1 hour, and the drop in the RBC level is then measured. There are 3 stages of ESR. ESR actually is done in exactly 60 minutes or 1 hour. The first stage is your stage of aggregation. It is the initial stage in which piling up of RBC takes place. This is known as your rouleau formation and occurring in the first 10 to 15 minutes. Now, this is the most important stage. The next stage is your stage of sedimentation, where it is the stage of actual falling of RBCs in which sedimentation occurs at constant rate. This occurs in the next 30 to 40 minutes, depending upon the length of the tube used. And the last stage is your stage of packing, which is also known as your stationary phase. At this point, there's a slower rate of falling during which packing of sedimented RBC in column occurs due to overcrowding, occurring in final 10 minutes of the whole procedure. The normal range of your ESR in male is between 0 to 10 mm in the first hour, and in female it's about 0 to 20 mm in the first hour because of the higher level of plasma protein among the females. Although ESR is cost-effective because it is available and easily done in many laboratories, it is also very nonspecific, and various factors can cause false changes in the results. For instance, there are factors causing false increases like increase in your fibrinogen, your globulin, cholesterol levels, high temperature or high room temperature, presence of macrocytic anemia during menstruation, pregnancy, or tilting of the ESR tube, which is a mechanical factor, and certain drugs like your metaldopa, penicillamine, procainamide, and vitamin A. It can also decrease falsely during episodes of cachexia, when the blood sample is coagulated, any increase in your bile salts, phospholipids, if you wait for more than 2 hours. So take note, we cannot divide the value of ESR if the tube was left for more than 2 hours, increase in adrenal steroids, hypofibrinogenemia, episodes of hyperglycemia, hyperalbuminemia, leukocytosis, microcytic anemia, and ACTH, quinine, and salicylates. There are also many disease condition or factor that can affect your ESR. There will be an increase in ESR during acute heavy metal poisoning, collagen vascular disease, carcinomas, cell or tissue injury, gout, infection, inflammatory disorder, leukemia, even myocardial infarction, nephritis, and syphilis. There are also few disease conditions that can decrease your ESR, like congestive heart failure, polycythemia, and sickle cell anemia. The next acute phase reactant is your C-reactive protein or your CRP. So this is an illustrative representation of your CRP. Your C-reactive protein or your CRP is the prototype of your human acute phase proteins or acute phase reactant and the most frequently studied one. Now, this is in contrast with your ESR, which is actually just a procedure to test for your acute phase protein or reactant. So your CRP has been named as C-reactive protein because it adheres to the capsule antigen of your pneumococcus. Plasma CRP production occurs again via the stimulation of your interleukin-6 in the liver. So your C-reactive protein is your prototype or your ideal acute phase reactants because of their involvement in many inflammatory processes. It assists in the recognition of damaged host cells and foreign pathogens and their removal. It also activates the complement system via the classical pathway. It increases your phagocytosis, and the level rises within a few hours and peaks within 2 to 3 days. The half-life is about 19 hours, and the increase in CRP levels is directly proportional to the inflammatory stimulus. Aside from the involvement of CRP in the inflammatory processes, they are also involved in vascular wall damage, in the activation of complement system, in the development of your prothrombotic states, in the opsonization of your oxidized LDL, in endothelial dysfunction, in oxidative stress, in plaque remodeling, and even in RAS activation. For these reasons, your CRP is also a good cardiac biomarker, especially with their involvement in the endothelial dysfunctions, plaque remodeling, and vascular wall damage. So currently, we have the so-called high sensitivity CRP, which can detect myocardial damage. In healthy individuals, the CRP level is generally 0.2 mg per dl, but due to microtraumas that occurs during the day, this level can actually increase up to 1 mg per dl, which is still considered normal. After a single stimulus, it can increase up to 5 mg per dl within 6 hours and can reach a peak value within 48 hours. So a value between 1 to 10 mg per dl is considered as mild inflammation, while any value above 10 mg per dl is considered a very high increase. CRP reflects an inflammatory process in its degree. Therefore, it is also very important in the follow-up of some rheumatologic disorders. So take note here the different conditions affecting your C-reactive protein levels. The level is normal or insignificant even in heavy exercise, in influenza, pregnancy, gingivitis, cerebrovascular accident, stroke, or angina pectoris, and only mild level in myocardial infarction, malignancy, pancreatitis, mucosal infections, and collagen tissue diseases. However, with the development of your high sensitivity CRP, this biomarker can detect myocardial infarction. So in this slide, the CRP level that we are referring are actually or is actually not the high sensitivity CRP. And very high levels are identified in acute bacterial infection, major trauma, and systemic vasculitis. Basically, CRP tests can screen for many other entities like your fungal infection, especially in pneumonia, sepsis, and even in tuberculosis. Of course, your chronic inflammatory diseases, especially those autoimmune diseases like your rheumatoid arthritis, inflammatory bowel disease, and SLE. And as I mentioned earlier, the CRP, specifically your high sensitivity CRP, can also be a biomarker for heart diseases like your myocardial infarction. So this is one of the methods to test your CRP in the laboratory using your latex agglutination test. Next is fibrinogen. So the most widely used or clinical utility of fibrinogen is in determining the presence of disseminated intravascular coagulation and of course to test for fibrinogen deficiency. But further studies show that this can also be a good acute phase reactant. Let's first take a look at the two main roles of fibrinogen. Fibrinogen is an important component of the common pathway of your coagulation cascade, and it takes part in the acute phase response after tissue inflammation and damage. High fibrinogen levels are seen in the following conditions: in heart or circulatory system disorders, in malignancies involving the stomach, breast, and kidney, as well as some inflammatory diseases such as your rheumatoid arthritis. It is actually a disease activity marker in familial Mediterranean fever, and high levels are found in exogenous use of estrogens as well as oral contraceptives, and thus this can also be a marker of hypercoagulability. Plasma fibrinogen level is normally around 200 to 400 mg per dl. In comparison with your ESR and CRP, fibrinogen is not a test that initially reflects the acute phase response because of its delayed increase, a long half-life, prolonged high levels after inflammation has passed. It also lacks stability in frozen plasma and preserved plasma, and these are some of the disadvantages of this test. Low levels of fibrinogen may be seen in liver diseases, prostate and lung cancer, including bone lesions, malnutrition, and some bleeding disorders. Obviously, there will be low levels of fibrinogen in a fibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia, as well as in obstetric complications and traumas, also in response to massive amounts of transfusion due to blood provided from the blood banks, and intakes of drugs such as steroids, androgen, phenobarbital, urokinase, streptokinase, and valproic acid. Next is your ferritin. Your ferritin is a protein that contains iron and is the primary form of iron stored inside the cells. The small amount of ferritin that is released and circulates in the blood is a reflection of the total amount of iron stored in the body. So your ferritin, again, normally reflects the iron stores in the body, with the normal values of 27 to 329 nanogram per ml for men and 9 to 125 nanogram ml for women, and it increases in cases of liver damage and malignancies. Next is your procalcitonin. Your procalcitonin is a relatively newer acute phase reactant and has gained some popularity during the last 5 to 10 years. So what is the procalcitonin? Procalcitonin, or PCT, is a peptide precursor of the hormone calcitonin. It is produced by your parafollicular cells, or the C cells found in your thyroid, lungs, and intestines. The levels rises rapidly in response to bacterial infection, but not with viral infection. The half-life is about 25 to 30 hours. So your procalcitonin is also produced in different organs of your body like thyroid, white blood cells, in macrophages, spleen, lung, liver, kidney, adrenal, even in CNS, as well as in stomach, pancreas, small intestine, colon, heart, muscles, skin, and even the testes. So during sepsis, wherein your body is also in a hyperinflammatory state, all of these organs or cells will be secreting procalcitonin at the higher levels, and thus your plasma procalcitonin will also be elevated. So again, your procalcitonin is elevated mainly in bacterial infections, especially bacterial sepsis, and to some extent fungal infection, but is only very slightly elevated in viral infection or almost normal. The lipopolysaccharides found in many bacteria can stimulate your interleukin-1 and TNF-alpha to stimulate other cytokines to induce the release of procalcitonin. While in viral infection, during the innate immunity, the most important cytokines are your interferons, which does not lead to elevation or stimulation of the cytokine involved in the release of procalcitonin. In a nutshell, your procalcitonin is an immunologically active protein and is induced in systemic inflammatory reaction. So bacterial infections induce PCT release, and the level is generally in direct proportion to the bacterial insult to the body. Viral infections, autoimmune diseases, transplant rejections, and allergic reactions generally do not induce PCT even if these conditions can elicit inflammations. PCT therefore is an indirect marker of a bacterial infection. It is a measurement of the body's inflammatory response to the bacteria. Other acute phase reactants are your serum amyloid A, which is a member of the apolipoprotein family, and it binds to high-density lipoproteins and alters the cholesterol metabolism. There are some studies which shows that serum amyloid A may be affecting the adhesions of phagocytic cells and lymphocytes, and they might play a role in the chemotaxis, causing the oxidation of high-density lipoproteins and playing a role in the development of inflammation in atherosclerotic coronary arteries, which, as we know, is an inflammatory condition. Your serum amyloid B comprises about 14% of your amyloid deposits. Your mannose-binding lectin, or MBL, is a member of your type C lectin superfamily and is a protein member of your natural immune system, especially in the innate immunity. It has a role in the first step immunity via recognition of microorganisms such as bacteria like your Shigella and viruses and fungi like your Candida. Many of the classical complement pathway components are acute phase proteins and have pro-inflammatory roles in the formation of immunity. Some acute phase proteins have anti-inflammatory properties like your haptoglobulin and hemopexin, having these antioxidant properties and have protective roles against reactive oxygen species. Your alpha-1 protease inhibitor and alpha-1 chymotrypsin inhibit proteolytic enzyme, while your alpha-1 anti-chymotrypsin inhibits the production of superoxide anion. There are also acute phase reactants involved in wound healing. Your FIBRINOGEN, for instance, assists in the adhesion of endothelial cells, as well as its proliferation and dissemination. Your haptoglobulin helps wound healing by stimulating your angiogenesis. So in summary, we have discussed some of the most common acute phase reactants, where C-reactive protein is the most ideal and the prototype among the acute phase reactants because it is elevated during the first few hours or even the first few days of the inflammatory process, but the levels drop significantly after a week. You also have your moderate acute phase reactants like your haptoglobulin and fibrinogen, which are steadily elevated over the course of the inflammation. And of course, we have your negative acute phase reactants like your albumin and transferrin, where the level drops also during the first few days of your inflammatory process. In conclusions, your acute phase reactants demonstrate the presence and severity of inflammation, and they can be used as a clinical guide to diagnosis and management for a long time. Your C-reactive protein and erythrocyte sedimentation rate, or ESR, are still frequently used in the clinic, even if they are non-specific because of their cost-effectiveness. They are widely available and easy to perform by many laboratories. Clinical studies are still in progress for the use of other acute phase reactants. The reference book for this lecture is your Henry's Clinical Diagnosis and Management by Laboratory Methods, and I will also upload a review article about acute phase reactants. This is the end of the lecture. Thank you.